What is going on? Welcome back to the Prymal podcast. My name is Dan, and if you're new here, this podcast is essentially a tool that I use to connect myself and you, the listener, with people that I believe have massive value to offer us in our exploration of the world, in our self-empowerment when it comes to areas like health, wellness, performance, business, entrepreneurship, success, every single aspect of our lives that can help us to improve and grow. My guest in today's episode is Sarah Moloney. Sarah is a trainer and a coach, but she's also a person who suffers with a chronic condition known as endometriosis. Now, I've always known that endometriosis existed, but as it'll become clear throughout this episode with Sarah, my lack of understanding and poor information around what this disease actually is quite evident. Having had a chat with Sarah about this beforehand, there was a couple of things that absolutely shocked me, such as how many people actually suffer with this condition around the world and the severity at which it can affect your lifestyle. It can completely change the way you live your life, and in many cases it does. Apart from suffering with endometriosis herself, Sarah just has such a deep understanding and knowledge when it comes to this topic, and we wanted to use this episode as a tool to inform and empower people, not just those who might be suffering with endometriosis, but also the rest of us who don't suffer but need to understand how it affects the people around us. And not just endometriosis, but chronic illness and chronic disease in general. Now, Sarah did tell me she was really nervous coming in here to record this episode, but trust me, she did an absolutely fantastic job of breaking this down. This is such a detailed and clear episode, but also because of Sarah's professional background and experience, she also has a super solid grasp of how the medical and health industry works nowadays, and the best ways that you can integrate multiple different approaches and build a team around yourself that's going to give you the best outcome for you, because everybody essentially is an individual. I really appreciate Sarah's time and input and energy on this episode. As I said she was nervous, but that does not come across in the way she delivered her information. I just want to thank her again for such a fantastic episode, and I hope you all enjoy and learn. Welcome to our shared journey to find the answers to questions about health, wellness, nutrition, performance, life and success, and to craft the most resilient, hardy and happy humans you've ever seen. Welcome to the Prymal podcast. Sarah Moloney, welcome to the Prymal podcast.
Thanks, Dan.
Thanks very much for coming in and joining me in this bright, early Monday morning. Yeah. So, Sarah, this is kind of a special episode, and we've been chatting a lot about this over the last week. I'm very excited about this. And recently I did an episode that was quite similar with Mark Tobin about Crohn's disease. But today we're actually going to talk about a very specific condition. You suffer with this condition, which is why you're sitting here in front of me. And when you came in to me last week to talk about doing this episode on this podcast, I was blown away by, number one, your knowledge on this, as in how deep your knowledge goes on this. And then number two, how little I knew about this. So essentially that's why we're doing this episode. One, because I want to learn. But also, I think the big takeaway we would like for people from this episode is if there's anybody out there who does suffer with endometriosis or who might know somebody, this is going to be a great opportunity to learn and hopefully to find some action steps that they could maybe follow afterwards. So, would you mind giving us just a little bit of your background and experience with endometriosis and kind of why we're here today talking about this?
Okay, so I was diagnosed with endometriosis in the Coombe Hospital in 2017. I'm 36 now. Since I was about 15 years of age, I had very painful periods. A lot of what could be classed as IBS type symptoms, gastro symptoms, vomiting around my period, a lot of bloating. I constantly was looking at different diets. Every time I went to the doctor about it, it was, oh, you've got IBS, this is it. And was never once asked about gynecological issues. And at that time, I was put on fairly heavy painkillers, but I was just told that painful periods are normal. That was just part of being a woman, kind of suck it up and get on with it. So I did. I was a very active teenager as well. I was constantly playing sports and didn't really want it to get in my way, but it did. Like I collapsed a couple of times in school. My mum would have to pick me up. she'd be like, Jesus Christ, it's just your period. We're like, get on with
Yeah.
it. She didn't suffer. She didn't really have any issues with it. But that was the line, you know, the party line, get on with it. So I was put on hormonal contraception probably about 16, and that was more to deal with the fact that the bleeding was getting very, very heavy. At the time, I didn't know I had a genetic bleeding disorder, which could have been contributing to it. So put on the pill, and essentially they were looking to stop my periods. Now, they never did, but it kind of, and this is something I'll get into maybe a little bit later, hormonal contraception can shelf the issue for you for a little while and can give, for some people, possibly a break from your period, but it doesn't stop the underlying issue, which at the time nobody knew about. I didn't know about it. Nobody else in my family was suffering like this, which is unusual for endometriosis, but I was also the oldest sibling, so we don't really know if anyone else in my family is going, because they're still younger than I was when things got really bad.
Okay.
So that was the start of it anyway. Like, that's 15 years plus tax probably at this stage. And it was only when I hit 30, this horrific fatigue started to creep in. I couldn't ignore the issues anymore. Now, there was an issue with, I think I was told it was like a chemical pregnancy. It was essentially a very early miscarriage in my early 20s.
Okay.
Again, this is all part of it. It's part of being somebody with a uterus. You just need to get on with it. It doesn't stop anything happening in the future. There was absolutely no investigations done whatsoever. So on I went. But by the time I hit 30, and at this time I was then working as a personal trainer, the fatigue was out of this world. Like, I could not drag myself out of the bed. The minute my period started, it was essentially a shit show. Like, I couldn't move, and the pain was getting more and more intense. I ended up in A&E a couple of times with it, excessive vomiting. I was bleeding out my back passage. I was bleeding when I was just going for a wee. Like, it was insane. But there was no sign of bladder infection. It just felt like a bladder infection.
Okay.
And then I did end up getting a couple of kidney infections and stuff like that. Loads of different things were happening. And I eventually went to my GP. I had changed GPs at this stage. My dad kind of suggested that I needed to get away from the people who were constantly calling it a IBS. He was like, I just don't think that's your stomach, Sarah. Go check it out. So I changed to two very good GPs and immediately was sent for a gynae consult. But immediately was a year waiting list. My insurance hadn't kicked in, and it was technically a pre-existing condition. So I lost the plot and begged and pleaded with Coombe Hospital to see me. Unfortunately, you kind of have to kick down doors in this country if you want to get seen. And I just made such an unmerciful fuss that I did. I think it was 8 months as opposed to 16 months I was waiting. Got in to see a gynecologist, and it was complicated by the fact I have this bleeding disorder. So I needed to see a gynecologist that had experience with bleeding disorders as well. So I did that, and she basically said to me, I think you just need to go on the pill. And I was like, oh, okay, why? And then my next question was, well, do you want to have a baby? And I said, well, does that actually matter? Is my quality of life not more important than my fertility? But apparently it's not in healthcare, but there we go. And eventually this went on. I did what they asked. I took the pill they suggested. I think I bled for 21 days straight.
Oh my God.
And the headaches, everything, it was crippling. They'd seen something on an ultrasound, but on my second ultrasound it was clear, and that's something really important to note. I had one unusual scan and one clear ultrasound as well, and both of them were transvaginal ultrasounds done by very competent people in the Coombe Hospital, but they weren't showing anything dramatically unusual, is what it was said. There was a couple of small cysts, but again, they were like, they tend to go away on their own. So that was the start of it. But I was getting progressively worse at this stage. I was collapsing. I would wake up in the middle of the day and there would be missed calls from my colleagues in work. I just hadn't arrived. I'd passed out getting sick, or like I just couldn't stand with the pain anymore. I'd taken painkillers and gone to sleep or whatever. So the gynecologist agreed to do a laparoscopy, an investigated laparoscopy. And at this point she was saying, I think it might be something more sinister. And then she said, there's still a possibility that it might be this condition, endometriosis. I already had a feeling that was the problem. I had done a little bit of research. My background is in science and physiology, so I had taken to Google Scholar and gone on a hunt at that point. So she said, no, I don't think it's that. Maybe it's more sinister. We need to go in and have a look. But I had to sign a piece of paper to see would they do what's called an ablation if they did find any endometriosis. I felt a little bit backed into a corner with that one, but I was desperate. And I know a lot of people in my situation would relate to that. Like, you get to a point where you're so desperate for answers that you will do whatever the doctors say to you. So I went ahead with that and was diagnosed with very mild endometriosis. And initially there was a little bit of relief having answers, but the pain just got worse. I never recovered from that surgery. I got to a point where I don't really remember that 8 or 9 months. All I did was beg, borrow and steal to get to the UK to an endometriosis specialist. I was very, very lucky. I had really good family support, and with the support of the credit union, thanks guys, I managed to get the money together to go and see a specialist. And it was like when you haven't been listened to, and I will say that the original gynecologist had refused to help me any further, said I wasn't a candidate for a different type of surgery. There are a couple of different types. They're not all created equal. And she said I had no evidence of any deeper infiltrating disease. I just didn't believe her, to be honest. You know your own body, you know something is wrong. So I said it to my GP as well. My GP also wasn't happy with the treatment I had received, so sent me for an MRI. At this point, I had not been sent for a single MRI. And on this MRI, he rang me. He said, I don't know how they didn't see this, but your uterus is actually stuck to your rectum. And there is obvious endometriosis on your uterus. And there is quite a large amount of it in the rectovaginal space. And he was like, if I can see that on a scan, I'm not altogether sure how they couldn't see it during a laparoscopy. So
this is your story there, because what I'm going to get into now is trying to explain to people who've just listened to explain a very, very distressing condition. I mean, continuous bleeding, chronic fatigue, massive levels of pain, a complete lack of understanding among some medical people. And my question is, why didn't I know what this condition was? I didn't know what endometriosis. I knew there was a condition called endometriosis, and I was like, and these are my words, that's a female health issue or something like that. That was all I knew about it. So when you spoke to me last week, I was like, when you tell your story and people are going, hold on, what the hell is this condition? Yeah. So would you be able to tell us what is endometriosis? Because I want to take everything you just said and carry it further in a minute. But first of all, just to set the scene for people, what is it?
It's not really a disease of menstruation. It is a whole body disease, an inflammatory condition. It may have links to some kind of immune response as well. It's endometrial-like tissue. So you know the lining of the uterus is your endometrium. It has glands, it has stroma, it secretes different hormones. There is tissue similar to that. It's not the same. It is histologically different, and it can be found elsewhere, like extra pelvic, so any other organ in your body, or within the pelvic cavity as well. So down the side walls, on your ureters. It can essentially be anywhere, and it's not a rare condition. That's the really scary thing. So it can affect up to 1 in 10 people who have a uterus or had a uterus at some point. It can affect, it's been found in fetus. It's been found in prepubescent teenagers. It has been found, albeit very rarely, in cis males. It is found to cause issues post-hysterectomy, post-menopause. So it's a far, I think the figures I read was 176 million people worldwide.
Whoa.
So it is not rare.
Okay.
It's just poorly understood.
It's poorly understood. And you obviously had a very traumatic experience in this country with a lack of understanding among the medical fraternity as well. Now, this isn't, as I said before, this is not a medical bashing conversation or anything like that at all. But it's important to understand that this is such a, again, I was shocked when you told me the numbers. It's such a widespread condition. It's so prevalent. It's so aggressive. It's so life-altering. And yet I didn't have a clue what it actually was, and most people really don't.
Well, a lot of really good, and this is the thing, the gynecologists are amazing, OBGYNs. They are amazing at other gynecological conditions, but unless you have studied as a surgical fellow and perform, I think it's like 400 plus endometriosis excision surgeries per year, you don't recognize the subtleties of this disease. I think there are up to 7 different appearances of what it might look like within the pelvic space. And unfortunately, the education for up-and-coming medical professionals is just not there. At the time when I was getting sick, I understand that the lecture was about 15 minutes long. Now, I could be incorrect in that now. I know there has been a huge change, and there are gynecologists who do understand it and refuse point blank to operate. They will refer on because they know they don't have the level of experience. So it's not, and this is a worldwide problem, and it does come down to the gender issue as well. And part of the problem is saying it's a women's disease. It completely removes the conversation from people who are trans or non-binary, and they end up getting even more medical bias than a cis woman might get. The care is not there for them. So we have to be very careful in saying that it is a women's issue.
Yeah.
It is a worldwide global health issue.
Absolutely, yeah. And again, because I know some people when they hear the whole gender thing, they start to kind of tune out a little bit. This isn't a social politics issue. No, it's a medical issue. If you had or have a uterus, you can have this medical condition.
Yeah.
That should remove all other kind of social or political kind of conversation around it.
Yeah.
Okay, so with endometriosis, you've talked about some of the symptoms there. Is there a scale for this? Is a scale? Not everyone has the same endometriosis, for example.
No, definitely not. There is a scale, and one thing about the endometriosis, say the lesions that you will have, they become fibrotic, and we'll talk maybe about early intervention a little bit later. The fibrosis causes adhesions. Adhesions are like bands of this fibrous scar tissue that can essentially glue your internal organs together, and it causes havoc. Like, there are people who have lost kidneys, there are people who have lost sections of their bowel, possibly in more than one place. Like, I know, like, other people I'm aware of in the community who are waiting on 11th, 12th surgeries. They have to have colorectal people involved. It can be on your lungs. There needs to be thoracic surgeons involved. It really is it's a nasty little disease. Like, and when it becomes fibrotic, it also grows back down into the tissues.
Oh, okay.
So this is coming into the difference between the two surgeries as well.
Okay.
So I might explain that for you in a minute.
Yeah, we'll definitely get into that. And just because you're mentioning growth of tissue and adhesions and stuff like that, how linked is this with like malignancy or stuff like that?
It's essentially it is classed as a benign disease. There has been some possibly higher incidences of cancer, but it's a correlation at the moment, and correlation doesn't equal causation, and you have to be very careful with that you don't look at one piece of research and panic that it might put you at an increased risk of cancer. The way the tissues seem to go on, we'll say, instead of going into like a malignant tumour, they become this fibrous scar tissue, which is no fun either and can completely destroy your life. But the research isn't there yet to say that it does or it doesn't, if that makes sense.
Yeah, it does. Yeah.
It absolutely does cause systemic inflammation, and that can be linked to increased heart disease and all other types of inflammatory conditions and autoimmune conditions as well.
Yeah.
But malignancy, the jury's definitely still out on that one.
Yeah, it's a funny one because we said it just before we started here as well. If it's not something that kills you,
Yeah.
like it's not considered a super serious, it's not a terminal disease, but
Yes.
something that doesn't kill you could leave you miserable or incapacitated for your
Completely.
entire life. And then what's the point? Like,
Yeah.
so that is as serious to me as something that has you.
But when the flare strikes and it's so unpredictable, you can't walk. Like if you have sciatic endometriosis, you can't walk. I couldn't sit because of where it was. I couldn't be in the car because I used to just be vomiting out the window. Like how that can be, like how your fertility can be put ahead of changing your quality of life is beyond me. I don't really understand that. Like if a woman or a person is coming to you and saying this is what's happening to me on a day-to-day basis, how they can just say like, oh, that's normal, on with your day. It's just beyond me.
And your obviously your experience is extremely difficult. Are there people who have endometriosis who kind of they suffer on a lower level and on a higher level than that?
Yeah, and this brings back, you did ask me about the staging. So there's a stage 1 and 2, and this is about the fibrosis as well, where you could have what's called superficial endometriosis on anywhere, but it's not deeply infiltrating into the tissues below, and there's not as many adhesions. There still can be adhesions, but then there's 3 to 4, and usually when you get into stage 3, you might have cysts on your ovaries as well. That's a good indicator that there might be deeply infiltrating endometriosis as well. And then stage 4 is where I ended up, and that means that there are nodules that are deeply infiltrating, and it is slightly dissimilar to 1 to 2. So it's almost like what you have at endometriosis is what you have, but it can become more fibrotic as time goes on.
Okay.
And also the scale, the 1 to 4, doesn't correlate to pain. There are people with stage 1 to 2 who can be completely and utterly crippled by their disease, and then possibly you would have someone who is stage 4 and they are trying for a baby and nothing is happening, and then they might go for some investigations, or they might end up getting an exploratory lap to see what's going on, and they will realise they've frozen pelvis and are covered with adhesions and they didn't have any symptoms. So it is a strange one, and it is highly individual, the disease as well.
Which could obviously lead to it being a little more difficult to diagnose or to
I think
correctly.
the delay is up to 12 years on diagnosis.
12 years?
Yeah.
Jesus.
Anything from 7 to 12 years.
Wow. And obviously there's a confusion or maybe an overlap between menstrual symptoms and stuff like that. Is I'm going to ask you personally, is this something that's every day for you, or is it just specific times in a month?
So before my second surgery, it would have been daily. Constant pain. Now I still have, for different reasons, I have a lot of underlying conditions as well. I didn't heal very well, so I ended up with a lot more adhesions than, say, somebody who'd had that type of excision surgery that I had the second time round. I didn't get quite the relief, and I had nerve damage from my first surgery. So I ended up with a lot of neuropathic pain, and that doesn't really go away, but we'll talk about management techniques about that. But in terms of the endometriosis, the pain can be any time. It's not just when you are bleeding, it is any time. Some people will find that it's ovulation and during menses, and other people will find they could be sick as a pig for the first week of their period. Then they're seeing symptoms again on day 4. Like it's all over the place, you know, and different symptoms at different times. And it's so hard to predict as well, like when you're going to be okay.
Yeah.
And that can make life very, very difficult. You know, people think you're fakey because you're cancelling this, that and the other. Or you're fine yesterday, why can't you move today? It's like, because I did all the things yesterday and now I'm in bits today. And that's chronic illness for you.
Absolutely, and chronic illness is something we'll cover. We keep saying we'll cover this.
Yeah.
We're going to go through loads here, but
You might be here a while, Dan.
look, it doesn't bother me at all. People are familiar with this now, but it is again just another particular question here. Is this something that could be underlying for people that could be triggered by something else? So it might be an existing condition for 10, 20 years that they might be aware of.
You've been seen to be born with it. There's numerous different theories, and I won't get into the research at the moment because it is still very unclear. But sometimes the patterns of where it's found look like something like in early development. And then there has been things about stem cells changing because it has been found in cis males as well. So it looks like you might be born with it. And then either hormones can trigger off the really awful symptoms, or epigenetics, your environment. It's multifactorial. And I think I just sent you this paper. I was reading just yesterday that people with autoimmune disease and stage 4 endometriosis seem to suffer a lot worse. There seems to be some kind of tie-in with the stage 4, possibly stage 3, and autoimmunity. And I know myself, I was recently diagnosed with autoimmunity, but there's so much of that prevalent in my family that it was almost an inevitability that I was going to end up with an autoimmune disease. But there's nobody else I know on both sides of my family with endometriosis, even though that would be unusual. It does seem to have a genetic or hereditary link as well.
Okay. That's what I was actually going to ask you that next. That's brilliant. And in terms of then, you mentioned fertility.
Oh, yeah.
Is this something that affects your fertility?
It can be. So 30 to 50% of people with endometriosis could have fertility issues. Not necessarily that you will never get pregnant, just that there could be delays, difficulty, possibly preterm miscarriages as well in our like early births and pain during pregnancy. I know some anecdotal stuff about ruptured placentas and that. Now I don't know what the prevalence of that is. So issues with fertility are common, but they don't, like, there are lots of people with endometriosis with children too.
Okay.
And sometimes with the correct kind of surgery, it can increase your chances of becoming pregnant. But repeated pelvic surgeries can cause issues with your ovarian reserve as well. So the hope would be going forward that people who are presenting with these symptoms, if they don't ever find one biomarker that they can test for, surgery is the only way to diagnose at the moment. Okay. Surgery and lab diagnosis. Maybe a one and done surgery with a very experienced surgeon might get you to that place if fertility is your goal.
Okay. Because it's obviously involved a lot of the time with the uterus and the lining of the uterus and the ovaries and stuff like that, does it affect hormone production?
It does, yeah. The lesions can secrete their own estrogen as well. So whereas hormonal treatments can give great relief to some, and in the case of a comorbid condition, adenomyosis, which is where the lining of your uterus infiltrates the surrounding tissues. And there's a couple of different types of that. That would be slightly out of my wheelhouse. It's not something I personally deal with, but I know a lot of people with endo do. What was I saying there? I've lost my train of thought.
That the tissue itself can actually produce its own level of hormones.
Yeah. So hormonal medication can help with the bleeding issue. So say the Mirena coil, I know some people have success with that, and that can give them a bit of a break, because with the adeno, the bleeding can be excessive, like mad clotting and really kind of something out of a crime scene, horrible stuff. But the Mirena can help with that. Not everybody, but with some it does. And then for hormonal medication, like surgery and expensive excision surgery is not available to everybody. And whereas the hormonal treatment it's not going to get rid of the endometriosis, but if it's going to give somebody some relief, then it is definitely worth a try.
Okay.
You know, and that's the thing. You have to meet yourself where you're at and what's available to you as well. Or it might just give you the relief to get to a surgery.
Yeah.
You know, in the meantime. And sometimes surgeons will use it post-surgery. Now, if you ever hear a surgeon saying we're using a GnRH, that's like putting you in chemical menopause post-surgery to clean up any endometriosis, hightail it out of there fast. That's not what it does. It just puts you in chemical menopause, which will stop you having a period.
Okay.
And the side effects from that kind of medication are huge. But again, I do know people who use it just to get a bit of a break.
Okay.
You know, from the constant pain.
Yeah, I mean, it's the more you speak here, the more it's kind of, there's a lot of traits with a lot of other chronic illnesses that you see nowadays in terms of it's very unique to individuals, doesn't present the same way, the treatment's not fully understood. Some avenues of treatment, like you mentioned GnRH, is it?
Yeah, GnRH.
Some people just like to use nukes to get rid of the problem, the sign that there's a problem, and they try and get rid of the sign, but it doesn't get rid of the underlying problem.
No.
So yeah, there's a lot of common issues with the way chronic conditions are treated, in my opinion, anyway. But just to stay for the moment on some of the living with endometriosis, kind of the lifestyle stuff. We were talking about fertility. What about intimacy and sex and stuff like that? Does it affect that?
Yeah. What I might do is I will read you out a list of symptoms with endo, because I didn't have them all. Other people might find that they relate to something on this list. So I'll read it out just to make sure that I'm not like forgetting anything. And also, this is not exhaustive. Yeah. Like different people have different things. So it's definitely not limited to. So it would be crippling period pain in people who menstruate, abdominal pelvic pain at any time, and that's often intractable and chronic. So chronic is like longer than 3 to 6 months in that particular area. Or longer of non-menstrual pain, so not just the cramping, it's just the continuous pelvic pain. The bowel can be heavily affected, and urinary tract issues can be heavily affected. You don't necessarily have to have endometriosis on those structures. Remember how small your pelvis is, everything is in there. If there's inflammation in the surrounding tissues, they can still have a knock-on effect on your bowel function. So you could have gas, you could have bloating, you could have food intolerances, bleeding from your rectum, bleeding from when you go for a wee, like it really distressing stuff that might make people look towards getting colonoscopies and stuff like that, whereas it could actually be a gynecological issue, not a gastro issue. And then, as you just mentioned, painful intercourse, penetration, sexual activity, like even orgasm can cause pain, because if you think like with endometriosis, your pelvis keeps spasming with pain, so you're getting a very tight, dysfunctional pelvic floor. If you've had any pelvic surgeries, you're going to have a tight, dysfunctional pelvic floor, and all kind of work, I'm going to say it, women's health thing is focusing on like tighten up that pelvic floor, girls, you know, but please don't stop doing that. It's a bad idea. It can cause a dysfunction without actually having any disease there. So look at this
just in general, really,
yes,
that's interesting.
Of course, like, think about it. If you were constantly contracting another muscle in your body, it's going to get crampy and sore and spasmy eventually, like, so you got to let it go and release it,
because that's such a huge part of physio, of post-surgical rehabilitation for females, post childbirth. It's constantly recommended that you do your pelvic floor and your Kegel and your,
in some circumstances, yes, definitely fire away. But even I've had postnatal clients who have a tight pelvic floor and they only realise that they're completely constipated, and that's why they're not able to fully release.
I did not know that.
That's something where a really good pelvic floor physiotherapist can help you either pre-surgery, post-surgery, or at management stage as well. Like, they are probably one of the best tools in the box when it comes to managing pelvic floor dysfunction.
Wow.
So I will leave some names with you of some people who are really, really good.
And I don't want to take you off track here either. This is just fascinating to me because it's so common.
Well, that's your background.
And I studied in physio as well, and I've had 2 children, one quite recently as well. But it's you constantly just hear this over and over and over again. Tighten up the pelvic floor. People with incontinence, women after having children, all that kind of stuff.
And that is important in those circumstances, and this just brings us back to the fact that everybody is
Everyone's
so
different.
individual. There is no one size fits all, ever. And anyone who's trying to railroad a person who is chronically ill into this, like, well, this worked for my granny's auntie's husband's cat, like,
stop.
you know,
that hearsay stuff.
Don't do that. Yeah.
And a pelvic floor physio who's not just going to tell you to do Kegel exercises.
Yes.
What do they focus on?
So, and it can be quite invasive. Now, if you go to somebody who is very experienced, they sometimes have an ultrasound machine as well, so they can do external assessments. I went for it. I was very comfortable with my physio. It was somebody that I had sat on panels with when I was speaking for Endometriosis Ireland, so I knew they knew what they were doing. And allowed to go for and I did need internal. I'd had 2 surgeries within a year. I had no connection between my brain and my pelvic floor anymore. So they were able to go vaginally and rectally. And the problem for me was rectally because of the amount of scar tissue I had built up, because that is where my nodule was. Okay. So they were able to go in and release everything and find out what was causing more kind of tightness, give me exercises to do, make sure that you're fully releasing if you are training, you know, to fully release the breath before you go again, and not allowing too much abdominal pressure to build up and that. So there's super helpful things, but you need to be assessed yourself. There's no point in me saying this, and this exercise work really well. They work really well for me.
Yeah.
You know, so you need a proper assessment by someone who knows what they're talking about.
Yeah. That's fascinating, and that is the best point you could possibly make there, because you've made it several times now, which you're 100% right. This is not advice for anybody. This is information, but you need to figure out what's going on. It's the same for any medical condition. High cholesterol, blood pressure. It's not just a blanket.
Just become
condition.
like the CEO of your own health. Like understand that you're in charge. You are employing these medical professionals to help you, but you are the employer and you are the one who's in charge, and you know your body better than anybody else. Don't let someone else dictate to you what you're feeling, because they haven't got a clue. They don't live in your body. And it's something I would say to even my training clients, like, if you don't communicate with me, I don't know. And the same thing goes when you're in a doctor's office. If you go, it's grand, you know, that it's not that bad, and you're essentially lying to them, then they have no concept of what they're dealing with. And also, like, don't let them dictate to you what your treatment plan is. If you've done your research and you feel that an MRI is going to help you, and you have the financial capacity to go ahead, or you have insurance or whatever, ask them to do it. Ask for the scan. And in most of the scan centres here do understand that a negative MRI doesn't mean you don't have endometriosis, so they're still going to have to use it, but it can be a great tool. You know, it really can. Like, ask your doctors. We better go back to this.
Yeah, sorry for sidetracking you there. That was fascinating.
Once I start. So the other, we were looking at the painful intercourse. So that, as I said, is something that can be helped with some pelvic PT. But when you're in the height of it as well, and this is something I would say about any kind of intimacy, it's not all about penetration, for one. There's lots of help and devices out there if that is your ultimate goal. There are these ones you can use, like dilators, over time to help you get comfortable with that. There's something called an O-nut, which I know other people have had good success with, and it stops the penetration from going too deep, and that can be a game changer for some people, like if that's what their sex looks like, because it is obviously going to be different with every couple. But something just to note, and I don't think it's really spoken about, is when you are in pain all the time and you've got like a disease that creates an imbalance in your hormones, if somebody touches you, you're going to want to bite their head off. If you have constant invasive medical procedures, you get almost this like tapped out, leave me alone situation. So when you are having issues in that area, try not to blame yourself and don't blame your partner. Communication becomes absolutely key, and finding some kind of way to stay close when direct intimacy is not possible is really important. And don't be in a situation where you feel like, and you can't help yourself, you're like, oh, I'm denying my partner this, that and the other. You know, your partner is responsible for their own sexual needs as well. You're responsible for your own safety, comfort and health. And if something is causing you pain, don't feel like you have to do it. You know, give yourself a little bit of space and maybe work with a pain management specialist and a pelvic physio and see if they can help you reduce pain in those situations, and also communicate with your partner to see if there's something else that you could maybe do.
Yeah.
Like it's a minefield, and it gets very upsetting sometimes.
Yeah, and I'm going to sidetrack you from the list again, because I just think it's such an important point. And I mentioned Mark Tobin before because he spoke about being in a relationship or having a family or other people that are involved with you when you have a health issue.
Yeah.
And that can be a really difficult situation for everyone involved, because the partner or your family member or someone can end up feeling very frustrated or angry or helpless, but that's a strange position to be in, because you're the one who's suffering with the condition. You're sick, you're in pain, you're fatigued. So there's lots of emotions in that kind of bubbling pot. You spoke about intimacy and sex there, and it's something that I find nobody wants to speak about here. I don't think it's the traditional, like, oh, we're all too religious. And I don't think it's just a lack of understanding and a real discomfort talking about these kind of issues, and talking about how do you find your level of comfort and safety. And ultimately that's what's going to lead you to be able to have a relationship with somebody, because I can only imagine that after 6 months, 6 years, 20 years, 2 decades of dealing with this, that's enough to put strain on any relationship. We have enough issues nowadays anyway with money and politics and all sorts of stuff. Nobody wants to speak about this, but it's at its core, it's one of the most fundamental parts of a relationship. It's not physical intimacy. It's being able to connect and communicate and be vulnerable and understand and feel angry and upset and frustrated, but find a way to work through that. And I just think you've spoken really well on it there, because nobody wants to talk about this.
No, and it is like, if you are in, say, a position like mine, you tend to get in on yourself sometimes and start feeling like, oh, I'm not being a good wife, or like I'm not providing for my partner, because when you marry somebody, that's one of the things that you promise to each other. But at the same time, they have made that promise to you, and you need to not see yourself as a burden. And I think the main problem, one of the reasons people don't talk about sex and intimacy, is because they ultimately see sex as this very one-dimensional thing, and it has to go exactly like that, or we're not doing it right. You know, they've forgotten the whole, like, as you mentioned so well there, the vulnerability and the closeness and the connection around that kind of intimacy. Like, you find your own way with any partner. Why should this be any different? And why should you be left out of the conversation because you have a disability or you have a chronic illness? There's lots of different ways to be intimate with somebody. It's just about finding the support and not accepting any less either. Stand up for yourself. You know, it's not something that you ever have to do. You just have to work with somebody in a way that you both find comfortable.
Isn't that such a it's touching to me, but it's such a real element of having, like, you have a chronic illness, you've been suffering with this for years, you've fatigue, you've pain, you've bleeding, all this sort of stuff, and you go in on yourself and you almost get angry at yourself sometimes. And it's to be human, obviously, is to feel these emotions. But again, why I'm so passionate about having these conversations on a microphone, because I'm interested anyway, but sharing this with people I think is so powerful, because you are going to go in on yourself. You're going to feel angry and frustrated, and you're going to be self not deprecating is the wrong word. You're going to be self-judgmental and all that kind of stuff. On top of dealing with a life-altering chronic illness that means you can't live your life, like, that's just the reality of it. So understanding how to communicate that with other people and to build your team, because we're going to talk about obviously building your medical team going forward, but your support team, your friends and family, your co-workers, your colleagues, the people you work with. Telling them this stuff helps me to understand. I'm understanding you. We only met recently, but I'm understanding you way more now because you're sharing this, which is massively valuable and powerful. So I just want to commend you on that. Fair play, because it makes a massive difference. It makes a huge difference, because now we get a deeper understanding. I've been on the endometriosis website you sent me. They don't tell you any of this stuff. No. Because it's human, it's different, it's deeper. So right, I'm going to let you go back to your list now, because we've loads to cover. But thanks for sharing that with us.
No problem. Now, what else have we got? Okay, so we've spoken about the possible infertility or delays to carrying. Then there's the immune-related issues and other comorbid disorders. There are more than one pelvic pain generator, and sometimes somebody will have more than one. So you could have interstitial cystitis, you could have adenomyosis, You could have had an infection at one point that hasn't cleared up. There's numerous different things. You could have had a baby and you have got pelvic floor dysfunction. You could have had an injury and had pelvic floor dysfunction. There's lots of different things, and sometimes having a condition like endometriosis then means that you've got this issue with pelvic floor dysfunction, or multiple surgeries cause havoc as well. And it's something that many people have not been able to avoid. It's through no fault of their own that they've had to have numerous surgeries because the first 1 to 9 was ineffective. But that has an effect in itself on your immune system. Before I had done my research, I felt that possibly having 2 surgeries in 8 or 9 months was the trigger for the development of an autoimmune disorder. But it was somebody else in my medical team who noticed, and this is something to mention. Don't blame everything on your endometriosis either. If there are other symptoms, always get them checked out. Don't sit and worry about it like I did for ages until somebody else in my medical team went, no, this is not endometriosis. On you go to the next consultant. And you might notice that you've got more allergies, migraines, chronic fatigue is huge. There's massive bloating around your period, but always get a second opinion. There are many generators for these symptoms, so don't blame it all on the endometriosis. There might be other things, so just for peace of mind, get everything checked out always. If you've got thoracic endometriosis, you might have pneumothorax, collapsed lung around your period. You could be coughing up some blood. You could have no symptoms. You might only see it or be noticed when you go in for surgery on your pelvic endometriosis. Something that is excruciatingly painful is the leg and lower back pain that comes with endometriosis. If you've got it on your nerves, on your sciatic nerves, it's horrendous. I've seen people unable to walk because of that. I had it very close to my sciatic nerve, so it did cause an awful lot of pain, but thankfully it wasn't actually on that nerve. And the physio was able to help me, but it took a long time after surgery to recover from that issue. And then, there's just so much, nausea. I'm surprised I didn't see that down there on that list. And this is why these lists are not limited to nausea and headaches, like random vomiting just the day before your period, or diarrhea, IBS-like symptoms as well, and food intolerances. All of a sudden, you can't eat a particular food that you love, or
that's crazy.
All of a sudden, it causes you to look 6 months pregnant. That's another thing that I think is one of the cruelest things about endo and infertility. It can cause such bloating that you look pregnant.
No.
And I know I was in a situation where I was going for a scan in the Coombe, and I had that bloating, and the taxi driver turned around and congratulated me and asked me how far I was along. And I think possibly my mood wasn't great that day. He didn't come out the best on the end of that conversation. But he didn't mean any harm. But that said, it didn't mean that it didn't cause significant harm that day. I was going in to be told that infertility was a huge part of my condition, and someone was congratulating me on pregnancy in the back of a taxi.
God, it's awful.
So there's lots of things that come with this.
Yeah, and again, just to keep reiterating this point, this list is not exhaustive. No. It's you mentioned that we spoke to start, some things could trigger endometriosis, but similarly, endometriosis is an inflammatory condition. It could trigger other things that are not then linked to the endometriosis anymore, so it can trigger another inflammatory condition. So it's just crazy how broad this is. And this isn't limited just to endometriosis as well. Other inflammatory conditions would share similar characteristics of triggering conditions. But this is, again, why it's so important to take control yourself a little bit. And it's a very easy thing for me to say, and become more aware of this. I say this a lot: take control of your own health, but that's not very easy to do when you're sick, especially. It's not easy to do when you're healthy. But when you're sick, it's even harder to do, because that requires energy and focus, and it requires an understanding of where to go and who to speak to. And we will speak about this as well. We've touched on it several times. Not all medical professionals are created equally, and this is not a comment on anyone in particular, but people are people, and people in different positions and different jobs who may not have exposure to this or experience with this or understanding of this or time for this or whatever all of that leads me back to the same point. You have to empower yourself a little bit with any of these conditions. But you've read out a pretty significant list of symptoms there. What about treatments? The basic question I'll ask you, is there a cure? There's no cure.
There's no cure for endometriosis. There is, say, the only way to diagnose at the moment. Now, there is huge research going on at the moment about common biomarkers. As some people will have inflammatory biomarkers. Some people actually will have autoimmune biomarkers. But that doesn't, there's no one across the board from stage 1 to stage 4. So that makes it very, very difficult. I think hopefully that will come in the future. They will find something. They usually do. But at the moment, the only way to diagnose is through a diagnostic laparoscopy. So that is keyhole surgery, and they would go in and have a little look around. Okay. And that should be done by someone who has done a fellow in endometriosis excision surgery. Your standard OBGYN could go in and have a look. But they might do more harm than good. And one, they might not recognise it. They might tell you you've got a negative disease. And say in my case, I was told I had stage 1, a very minimal endo. And that surgeon did more damage by doing a procedure called ablation. Now, ablation does still have a 20% success rate. So if that's the only available to you, and I know there are plenty of people out there who have had relief, or at the very least temporary, a couple of years relief out of the ablation. But in, I think, 80 to more % of the cases, it can make things worse. Because what ablation does, and you remember the tools are not the technique. So they would be using a laser. They could also use a laser for excision surgery. So just because it says laser does not necessarily mean you're getting excision or ablation. You need to know what their technique is. Okay. So the ablation is like a surface burn, like a cauterization of the top layer of the tissue. So that inflicts more tissue damage, and that can cause adhesions and fibrosis there. And also it doesn't deal, it's like just getting a blowtorch on the top of an iceberg there.
It's like a creme brulee or something like that. Because didn't you say it goes much deeper into the tissue? It can
go deeper in some cases. But even in superficial endometriosis, you should be taking back the layers of peritoneum, making sure that there's not anything there. And it can be very subtle as well. Like there might be a little blister, there might be like a lack of vascularization. Like I won't get into that because I'm not a doctor, at the end of the day, but spend far too much time on YouTube. But they should be able to recognize that. And the most distressing thing about this is a lot of times you're told, oh, it's all in your head, the hysterical idea, and that goes back to the whole gender issue as well. But if they don't recognize the disease, you could get a false negative, and you can imagine the psychological damage that would do somebody. So they're like, you're telling me my pain is all in my head then, whereas in reality they might have missed some. And even when you get to somebody like my second surgeon, who was phenomenal, he was 4.5 hours trying to repair and remove the damage that had been done by endometriosis and by a previous surgeon who, with the best will in the world, really wanted to help me, but just didn't have the experience in it. Yeah. So probably through no fault of their own. The only thing was there was a mishandling of my particular case, because I went and read my medical files, and they did see some striations, nodularity in the rectovaginal space, and then decided not to tell me about it. And there's not very much that can be. So on went that, and the second surgeon was just amazed. I was like, is it possible that it grew? And he was like, no, no. But that cost me, I think, €11,500. I had to go to Birmingham to be operated on, and then you've lost your aftercare then, because you're not under a gynecologist in the HSE then. Thankfully, there are a couple now. There was one person whose waiting list for 4 years, because they're the only person in the country who are qualified to do the very complicated surgeries that endo can sometimes bring. But now there are more. We've now got 2.
Oh God! Yeah.
And one of them has a really good team as well, who are very. They're open to suggestion and open to other opinions, which is unusual here. Yeah. So there's definitely an improvement, but not enough.
You said something important there. The best will in the world, and again, I like to repeat this point, because sometimes when we're having these conversations, it can sound like you obviously had a very negative experience. That does happen.
Yeah.
And I said it, doctors and nurses, physios, therapists are like everybody else. They're people like
they're
us.
human.
They're human and they make mistakes. They went into that career to help people, but they might not necessarily have the information they need. In my experience, most medical professionals are doing their very best to help the person.
They
in front
are,
of them.
and you've got to understand that the way that our healthcare system is set up, these people are under the
Massive
phenomenal pressure.
Yeah.
You know, they might not have time to keep up with the research because they're delivering babies at all hours of the night. You know, and this is the difference between an endometriosis care centre and an OBGYN. They are phenomenal gynecologists in that area. It's the usual thing. Stay in your lane. You know, if you don't have the training, get out of there. You shouldn't be doing it. But there's like, how are they supposed to know if they've never been told?
Exactly. Yeah,
You know?
it is unfortunate, but again, it reminds us to be empowered ourselves and do this ourselves. And you also, you didn't mention it there, but did you say to me last week the word hysterical?
Yeah.
Where's the word hysterical connected to?
Yeah, hysterectomy. Okay.
Hysterectomy. And now that you say it, I'm like, why did I never see that before? But what's the background there?
So, listen, we'll go into the hysterectomy and endometriosis and maybe what's happened there, because I'm just going to get up on my soapbox and we go down that road. Nobody will benefit from me going on a rant. So, a hysterectomy is not effective treatment for endometriosis, nor is pregnancy, by the way.
But they recommend it.
They do recommend that, which is fun. But if you think about what endometriosis is, it is outside of the uterus. There is that other condition, adenomyosis, which is within the uterus. My surgeon removed endometriosis from the surface of my uterus. He did not need to remove my uterus. If he had done that, I would have had to deal with post-hysterectomy issues and the removal of a completely viable, healthy organ. There is no need unless you have issues with the uterus. And there are other conditions which may lead to somebody making that decision, and it is a massive decision to go ahead and get a hysterectomy. But that would treat gynecological cancers, fibroids, if they've gotten out of control, or adenomyosis. It does not treat endometriosis.
Okay. It seems to be a go-to treatment for a huge range of these type of conditions. Yeah. And I read some stats on the websites you sent me that were quite scary in terms of the numbers of hysterectomies that are performed. And then I compared that to the recovery or curing of the endometriosis, and there's no real, again, very careful how I say this. In some conditions, I'm sure it's beneficial, and in some, it will be the right way to do things. But it doesn't seem to be the right. You've got endo, hysterectomy. That's the way to go. Yeah, it doesn't really seem that that's the. But it is a, because I kept seeing it as a recommended treatment for endometriosis. And I was
but if you're going to treat endometriosis with hysterectomy, are you going to remove all the other organs that it can be on as well?
This is kind of what I was thinking when I was looking at it. You mentioned something there as well about one of the only ways to identify it is to go in. But your UK surgeon was able to spot it on a scan. Is it possible to see this on an MRI?
My GP saw it on an MRI. You can see the deeply infiltrating endometriosis on some scans, and some, I know in Australia they have a very specialised way of doing ultrasound that can give the surgeons a guide as to where it might be. I don't know if we have the same technology here yet. MRI and scanning is a really useful tool, but we all know that it has its limitations as well, and you won't see what could be a massive superficial disease in an MRI. You tend to only see it when it gets to a certain depth, and it showed up. Some of mine, it did not show up at all, and I got clear ultrasounds as well. So they are a tool, and a very valuable tool. And if you've got somebody who is really experienced radiographer, they might be able to do a better job. And I know there are protocols in the UK for MRI that would be different to what's here, but anytime I asked for them, I was met with a blank look. So they're like, what?
Okay. Yeah. So again, it just depends on where you go and what kind of tools those particular people are familiar with using. Yeah.
But I did notice on the scan centres here on recent MRIs, they were like, they could see my adhesions, they couldn't see active lesions, but they have a disclaimer now saying, no evidence of this, please go off symptoms and refer to a specialist gynecologist.
Okay.
So there's definitely been an upskill in that regard, in that they're like, a clear MRI does not mean that you have no disease. And you could notice something like if it's inflammatory, there could be free fluid in your pelvis, which might be like, sometimes that can mean nothing, and sometimes it could be an indicator that there might be something else going on there, you know. Or if organs aren't moving on a scan, are they stuck to something, you know? So that was a line I was given after my first surgery, like, oh, we couldn't see underneath your uterus. And I'm like, well, if it wasn't stuck to my rectum, you might have been able to. But like, how you miss that, lads, is beyond me. But there you go.
That's nuts. Is there, because you mentioned this can be progressive, it can get worse. Is there anything to be said for early detection and early intervention? Is that a possibility? Yeah,
definitely. They're treating it more aggressively now. I think if teenagers are presenting with, like, there's, maybe we'll talk first before we go down that, with dysmenorrhea and primary and secondary dysmenorrhea.
Perfect,
Primary means that once you start your period, you start getting an awful lot of pain from day one. And that can be to do with prostaglandins, which are inflammatory chemicals and make things very sore and crampy. Secondary dysmenorrhea is pain with a condition. So something like endometriosis. There are obviously other conditions as well, but we won't get into that today. If a teenager is being stopped in their tracks, they can't go to school, they're like, excessive bleeding is not always part of this. It can be pain, it can be nausea, it can be bloating, there's lots of different things. Then it is worth having a look. But you would need someone very skilled, because they might not have gotten to the fibrotic stage, so they would need to be able to notice the subtle difference in the tissues and excise it, get it out of there before it gets fibrotic and causes like unbearable pain and damage to this person.
Yeah. You've kind of given me an answer was forming in my head as you were talking there. You get somebody who's a teenager who starts to experience these severe symptoms, and they go to their doctor, their GP. I'd say there's a massive reluctance to jump into, we'll do some laparoscopic surgery here to try and figure out.
Go on the pill.
Go on the pill.
Yeah.
Does it right. Let's do this for the next 10 years.
Yeah.
Until we get to a point where it's so bad.
Yeah. Or the other thing is, because apparently fertility is more important than quality of life, until like you are going to realise your potential as someone with a uterus and go ahead and have a baby. Like, I'm sorry, but that is not the be all and end all. We're more than just our ability to carry a child. If it's getting to that point, it's all gone tits up, in my opinion. You know, it should be early intervention as much as possible. Some people don't show symptoms until later. So
just I don't think I'm following this 100%, because I know what you're saying in terms of fertility. Are they prioritizing not doing anything about endometriosis, not have to go in and upset the uterus so you can have a child to protect your fertility, as opposed to, okay, I know you're really sick, but if we do anything, we could upset your fertility?
No,
is that the approach?
Like that doesn't make sense. It would be more of a, let's go on the pill. You don't need to do anything about this now, probably from lack of information as to what the condition is. Not that, like, you know, pelvic surgery can damage your ovarian reserve, but it can also increase your chances of becoming pregnant if you've got one of these conditions. So I wouldn't imagine that that's the reasoning there. It's just that they think that hormonal contraception will stop the endometriosis in its tracks.
Okay, that's fair. And then I asked you this question a while ago, and it's a very interesting answer: holistic or functional approach to something like endometriosis. Now, I know it's going to be a kind of a complex answer, because obviously there's lots of other symptoms, and you can manage those with maybe a functional approach, but at the end of the day, it is a disease. Is there a place for a holistic? Now, I say the word holistic very carefully. It's a word we need to reclaim, the word holistic.
Did you see me twitch?
I saw the twitch, all right. Holistic does not, and anyone who's listened to me before knows how I feel about that word. I think it's a very important word, but it's including everything that you could possibly include that is beneficial, from lifestyle and diet to, if you want to include holistic treatments in that. It's not just burning incense and praying for it. Like,
Yeah.
holistic to me means including every single tool that you could possibly use that could benefit your situation.
Definitely.
Is there a place for that?
Of course it is. And just to say, example this morning, like I get really stressed about public speaking. I woke up in pain this morning. So very simply, you could look at managing your stress. Stress is always going to exacerbate a chronic condition. It's always going to increase fatigue. Meeting yourself where you're at, you know, your energy levels. Like we all do this. Anyone I know who's chronically ill, you have a good day and you go bananas. You do everything. 20 loads of washing, you're feeling amazing. You know, off you go. The next 2 weeks, you cannot move. So about managing your time, it takes a long time to do that though. You really have to get to know yourself. And like there are tools, of course, there like yoga can help some people. If somebody mentions yoga to me, I want to punch them in the face because like it you know what I mean, it's not for everybody. Like but I'm looking at that more from a stress management as opposed to this is not going to make your disease go away. It's just going to make you feel better for a few minutes, as in most complementary therapies do. They make you feel better, and if anything can make you feel better when you're suffering, it's worth trying. Do whatever you want to make yourself feel good. Honestly, don't discount anything. Try everything. But don't get taken advantage of. Essential oils aren't going to make your chronic illness disappear. Following a very rigid diet is not going to make your endometriosis disappear. It can help with some symptoms like food intolerances and that. But that is highly individual. I would be telling people with the disease to track their symptoms. If they have got GI symptoms or pain symptoms, track your alcohol intake, track your food intake, see if there's anything in there that you could change, move around, replace that might make you feel a little bit better. It will help with the symptoms. It won't cure you. Like there was a huge push there for a while for everybody with hormonal issues to go vegan. That made me really ill. You know, of course, I was open to changing, but my iron levels tanked, and so did my B12, and my chronic fatigue was 10 times worse. That said, I know other people who feel great on it. So it's about finding something that works for yourself. Things like massage, if you can handle, the touch can release muscles and tension and all that kind of stuff around the area and just help you to breathe again. Pelvic PT is, if it's available to you, is a really good tool, but you need someone who is well versed in pelvic floor dysfunction or conditions like that. Then, of course, you could try things like magnesium. They might help the muscles relax again, if it's available to you. If your blood level suggests that you need it or don't, you know, be careful with the complementary therapies. Find what works for you, and don't get taken advantage of. I know that I've already said that, but I've even seen it in support groups and that people will come in and say, this worked for me. And then ultimately they're selling something to you. So just bear that in mind. Stress reduction is huge.
It's a very difficult line to walk when it comes to health. And I feel like you've dealt with it really well there, because you'll get the support groups and the friends and the family, they swear by this essential oil or that diet or whatever that. And on the converse side, you'll get your doctor not telling you any of this. And the reason I believe is because they can't take responsibility. You're completely different. They know that what their thing is. I'm going to do a surgery, or I'm going to recommend a scan. They can't tell you about what diet might be right for you, or what essential oil or stress or anything like that, because you could be completely different to the next patient or client that comes in. So they're reluctant to recommend anything. So you'll often get resistance from your doctor when you bring something. Should I try this? A good doctor will probably say to you, do you know what? If it feels right, it's not doing any harm, give it a go. I don't know, but let's see. Let's build it in and try it out. But I find most people are just reluctant to say that because they can't take responsibility. It's not part of a treatment protocol. It's not proven. There's no data on it. So we can't really say, part of your endometriosis treatment is surgery and cinnamon oil 3 times a week or whatever.
Like, and that might work for somebody. It is very much about what you believe is going to work for you as well. Like, there is an obvious medical condition here that we're dealing with as well. Like, there are lesions of tissue inside you that you can get removed. Now, I'm not saying that surgery fixes anything. I've had 2 and I'm still not okay, you know. But it did make my life considerably easier after seeing a specialist. That is not available to anybody. I was extremely lucky to have the support there to go and do that. But maybe other things might help, like hormonal treatment or complementary therapies might be the best shout for you there. Also, like, when you're in chronic pain, you don't want to move, you don't want to exercise, you don't want to do anything. I found that the biggest kick in the teeth. I've been training in some manner since I was 4 years old. Like I don't know how not to exercise. So I had to really kind of dig deep on that one and find different types of movement that were safe and effective and didn't leave me flat on my ass, because we don't just have this condition. We don't just have these therapies. We have a whole life outside of that we have to manage as well. And the world doesn't stop just because you're sick, particularly if you're chronically sick. You might say like me, you might be self-employed. The money might not be there for you to take days off. You still have to show up to work, and you have to kind of figure out like a balance there. Like if I go on the piss this weekend, I might be in a whole load of pain for 2 days, but I still have to show up for work on Monday. So is it worth it? And that's just a really general example of, like how I manage it. It's not worth it for me. It causes me more pain. So I'm definitely not going to do it. But sometimes then like you kind of rebel against that and go, I'm doing it anyway. Like,
yeah, you have to live.
Yeah, exactly. You do have to live. And sometimes it is worth taking it on the chin. And that's one thing I will say about exercise and learning to move in a way that feels good, because yes, again, it won't cure your endo, and sometimes it can make a flare worse. That is the God honest truth. I have done so many different types of gym training and I will still get a flare up of pelvic pain afterwards, because the fact that there's so much muscle there, it's going to hurt afterwards. But I'm going to do it anyway, because if I don't, I know my joints are going to be in bits. Like there's the offset, the things that exercise will offset. And also just for those few minutes when I'm doing it, then I feel like I can forget about the illness for a little while. And that is a management tool for me. It doesn't make the pain go away, but it certainly makes me feel better about myself. So I'm going to do that.
This is something I'm very interested in. I'm uniquely unqualified to speak about it in this situation, and you're uniquely qualified to speak about it. Is this victim mentality? You can become a victim. I say this, and it might sound insensitive because I don't know.
Yeah.
And it's easy for me to say,
yeah,
well, you can't be a victim. It's easy for me to say that.
Yeah.
But you're living that. You've just explained there in that last 2 minutes there, you're living it. You can very easily become a victim of this condition. You could become endometriosis and your entire life is endometriosis, and you don't do anything because it's going to flare up your endometriosis.
Well, I'm going to give you another side to that. Like, not everybody has the capacity to get past that, and it's very easy for somebody who's in the full of their health to say, well, you've not tried this and you've not tried that, and it becomes almost a blame game, whereas the person who is suffering is being blamed for their illness. And having someone in their full health shout all these things at you, if only you were doing that, if only you were doing that. It's like, are you telling me that this is my fault? I have done all the things, and let me tell you this, I have done all the things that I was supposed to do, and I still got sick, and I actually got sicker even after doing all the other things that I was supposed to do, so we have to move away from that. Like, people can be victims if they want. Leave them off and let them deal with their lives. We have to have respect for individuals in that regard. If that's how they deal with their illness, let them. It is not for us to tell them how to get on with it. I know what I choose to do, and that's my personal choice. The person beside me experiences life in a completely different manner. What if they don't have the support structure there to help them manage those thoughts? Like, of course they're going to slide into feeling absolutely horrific, and it is awful. And there have been times where I have been miserable and gone, I can't do this. This is endless. Like, it never goes away. But something in me just kicks in because I have other structures in place to help me. Work has become a wonderful distraction. I go down and I see my clients and they're all so happy to see me. Like, I just find that shit infectious. I'm like, oh, cool, great, you're here, It brings me out of myself for a little while. And I have my painting, like I use art as a distraction, and I get up afterwards and I can't move my neck and I can't stand up, but I haven't thought about it for an hour. So distraction always worked better for me. It's not the case for everybody. You can't put yourself in someone else's shoes.
Yeah, absolutely.
Don't live their life.
You don't live their life. And I constantly think about this because, again, I use that phrase, victim mentality, but again, that's different for everybody.
Yeah.
It's completely different for everybody. And do you think somebody who doesn't have the capacity to do that, I kind of half know the answer to this question, but is there a facility out there that can help those type of people? Is there a group of people? Is there a movement? Is there a community
groups.
support?
Yeah, I think educating yourself. I did notice with myself that initially there was this catastrophizing of the pain in that, like, oh my God, this is so bad. There can't not be something really horrific going on inside me. Now, there was, but like I wasn't going to drop dead on the spot. And once I had the support and my medical team in place, and I knew what it was, having the diagnosis was powerful in itself. Like, you're kind of go, oh, Jesus Christ, here we go. And I knew enough at that point that I was like, all right, I'm in for a lifetime of this.
But you're not crazy.
But I'm not crazy.
Yeah.
I'm not making it up.
Yeah.
I am deserving of the care I asked for in the first place. That is a good thing, actually. If a doctor refuses to do something that you ask them for, say you ask for a scan and they say, I don't think it's medically necessary, go, okay, that's great. Thanks for your opinion. Can you note that in my file? Just put it back on them and see how they respond in that. Like, if you've asked for something and a medical professional has denied it to you, let them explain as to why.
Why do you think, because I've seen this in many different, not endometriosis, many situations, as simple as like a wrist x-ray. I want to get my wrist x-ray. Oh no, I don't think you need that. Why do you think that response is there? Like, I would like something from my health, please. Oh, I don't think you need that.
Is it possibly distracted from the patient they had and only had 7 minutes to deal with beforehand?
Definitely,
is it the 45 hours of work they've done that week without any support, or maybe they haven't had a day off in 8 weeks because the GP practice is fried and they're overworked anyway. It could be any number of things, and sometimes ego might come into it as well. You know, they've spent a long time studying, and then they've somebody coming in telling them how to do their job. So you do have to have respect for the doctor in that, right? Like,
oh yeah,
you
ask
in a certain manner, but I still wouldn't. I wouldn't take no if I don't, or at least have the discussion, and I want to know their reasonings for it.
Yeah. Like I know there's some people who go in and they I've googled this and I demand this and ABC.
Yeah.
But realistically, you want anybody you're working with to be part of your healthcare team.
Yeah.
You want a team of people who are all communicating with each other and communicating with you. Now, this is very idealistic. I know the system doesn't necessarily support that. However, if I go in as a client or a patient or whatever, and I say, look, I feel this way, I'm thinking this, can we try this?
Yeah.
I would think, and I've also experienced this, by the way, this is not a blanket statement at all. I've also experienced doctors who go, oh yeah, okay, that's a great idea. That sounds great. Yeah, 100%. Let's get that sorted. I'll keep in the loop. Let's talk about it. And it's amazingly empowering as well. And you mentioned something really powerful there, because I saw this in the years I was working in the clinic. As soon as somebody realised, oh, are you going to help me?
Yeah.
There could be something. You just see it, just the weight of their self-doubt melt off them, and they're like, I already feel a little bit better.
Yeah, and there's also, like, it's extremely emotional, you know, like, you second guess yourself all the time in anything, you know. Am I good enough to be here? Am I good enough at my job? What am I doing here?
You get gaslit a little bit as well by people making you doubt. Hold on, I was sure about this, but they're after telling me this.
Something that will happen is you will tell somebody else, maybe in your circle, and they will make a throwaway statement like, my auntie has that and they're fine.
Yeah.
Oh, that's good for them. I'm delighted your auntie is fine, but I am not, you know, and that can even happen within. That's one thing about support groups, and that do be careful, because you've got a lot of people where it can be amazing, and I've made some friends through the community which are like, I don't think I could be without them, and we've been very cautious with each other in terms of boundaries. You know, I'm not feeling good, could you maybe not tell me everything that is wrong with you today? And we understand that about each other, whereas somebody else might not, you know. But within support groups, sometimes there's a bit of like a dumping. If one person is kind of having an okay day, they end up being the ear for everybody else's issues, and then they're kind of sitting there going, well, I don't have them, maybe I'm not that sick.
Okay,
and that's going to get in on you and make you doubt yourself. So I think, yes, find a community, yes, find people who understand and that, but still be conscious that you are the one who's in charge, and you're the one who's experiencing your life and your pain, and it is valid. You know, just because it's not the same as somebody else's doesn't mean it isn't there. You know, so just being wary about that.
Absolutely. I think that's brilliant. I think that's brilliant advice. Talk to me about pain, because we've mentioned pain consistently throughout this entire thing. Managing pain is a huge part of living with this condition.
And that's something you're going to have to fight for. Like, there's a terrible like worldwide thing that you're just looking for painkillers. And I tell you something, those painkillers are dreadful. Like being on them is no picnic, but it's that or not be able to function at all, you know. So it's like function with all these horrible side effects. And like, because I'm now able to stand because my pain is somewhat manageable. It doesn't mean it's gone. But the medication can really help. But understand that people who are in chronic pain, we're not asking for these for the crack. Like, I'm not standing on a street corner selling my bloody prescription. I'm using it sparingly because most of the time it makes me feel sick.
Yeah.
But you do have to fight for it. Now, I have been lucky that, like, I don't have any other conditions that might influence a doctor's decision in terms of what medication that I have. I have a genetic disorder, 2 of them, which means that some medication doesn't work for me, so I'm very limited in my pain care. So I quite quickly got referred to the most wonderful pain specialist, an anesthesiologist who understands pain and understands the different types of pain I was experiencing. So I had endometriosis pain, which is a joy in itself. And then I had this neuropathic nerve damage. So almost like my brain had been rewired. And this is something else that might be said to you in pain management. And don't think they're telling you it's all in your head. They're not. They're explaining that your pain signals, your central nervous system can get messed up by being under assault, and then can be almost overactive in that smaller issues than you once had, say it's post-surgical or something like that, can cause still an extraordinary amount of pain. And sometimes your pelvic nerves they're so complicated and complex that they might continue to cause pain even though the endometriosis lesions have been removed, because surgery is an assault on the body as well, you know, so there can be scar tissue. But a lessening of pain is where you're looking to get with these people. And I even notice when I'm speaking to my pain doctor, and they have been the one who has probably helped me the most, they were also the one who advised me that the pain I was continuing to experiencing had nothing to do with endometriosis. So I got very, very lucky with this particular doctor.
Okay.
They knew their shit and were extremely empathetic about what I was going through, and I wasn't made to feel like it was all in my head. I think at my first consult I was there for an hour and a half. And they don't withhold medication either. You have been prescribed it. Your GP has constraints over what they can prescribe, and also they get worried, you know, they don't want to be writing a prescription for whatever it is, you know, and they would prefer you to be under pain management. So ask to be referred to somebody. Like, it's really important, and somebody who understands all the different pain generators as well.
Okay.
If there's something there that can be helped medically or surgically, your GP might be able to refer you to another consultant who can help you with that. But if it's coming down to other types of pain or managing long-term pain, then you do need a specialist there.
Okay. And am I allowed to ask you about home-based remedies for pain management?
Yes. I have a wonderful friend who is a fantastic advocate for cannabis use in this country, and I didn't really have any experience of cannabis except for a couple of like vomiting into a sink when I was about 15 or something. Like, I really didn't know anything about it, and I had avoided it because I don't react very well to pain meds. I don't like them. They make me feel fuzzy, and I am a personal trainer. I have to be safe. My clients have to be safe as well. So sometimes I have chosen to go to work in the horrors as opposed to taking one of my tablets. But also I don't sleep very well with my other conditions. So this wonderful person, and I will leave their details because their page is fabulous on Instagram, suggested that I try THC. So I got edibles because I didn't want to smoke. So tried the edibles, and I remember crying the next day because it was the first time I had actually properly slept in so long. And that alone for me was worth it. Like, I know people who use it during the day, and that's not an option for me. I'm doing a master's as well. Like, it doesn't, like, it makes me too sleepy, and obviously you can't get the strains you want here as well. Like, you're taking whatever's available, and I'm making it into edibles in the house and gassing my poor in-laws out of it. But it helps me sleep, and that was something that was just so far out of my grasp. And I always found that like sleeping tablets and that didn't get me restful sleep. This did. So I was a much happier individual with consistent use of the THC, and it works for different reasons for different people as well. So
yeah, it's a fascinating world, and again, most people are very hesitant around this, and they're only starting to embrace CBD, which is obviously one of the other compounds in cannabis, and THC is kind of still demonized a little bit as it's the psychoactive. That's the bit that makes you go crazy. That's the gateway bit, but the more we learn about this, I know this is very well researched. It's massively
the research is there.
We're so resistant to this in this country, and there's all sorts of reasons for that. But bottom line, it's another avenue that can improve your quality of life. And what the hell else is the point?
Exactly. And one thing I will say, I'm very, very upfront with my doctors. They get complete honesty. But it took me a long time to tell my rheumatologist about it. I knew my pain doctor would be open to it. They're open to everything.
Of course they are.
Really are. They understand pain so well. But I told the rheumatologist, they were nearly up out of their seat with excitement about it, because they're reading the research. They're dealing with people who have autoimmune chronic pain as well. And they were like, anything that makes you feel better, we're hoping eventually we're going to be able to prescribe this. They really are so receptive. Any of the doctors who, now I know that that's my experience. I think other people have been told, they've been dropped from their doctors for the use of cannabis. They're like, you're clearly addicted to drugs and you don't need any of my help or pain meds. So there's that side of it. I was extremely lucky. I got an amazing reception about this, and it does make me sleep. So I'm going to continue to use it.
Yeah, it's amazing. And this is not a recommendation for the use of marijuana, but again, educate yourself and learn. Yeah. Look, Sarah, there's so much information in that. I know we're a little bit tight on time now, but we've covered such a vast amount of information in a small amount of time there. So for anybody who might be listening, who maybe has now gone, maybe that's me. Maybe I should look into something, or they have somebody who may be quite young and suffering with some of these symptoms and has gone through the traditional take the pill, and they're kind of on this path now. What's a good place for, on the same note, there might be a 70-year-old person out there sitting thinking, this is not just, you get it when you're 14 and you grow into it. Like,
still dealing with this, 20 years after menopause. So a good start with that, and we kind of look at, I wanted to build some kind of a step ladder for people like that they could go through. Your GP is usually where you have to start, and have a really honest conversation. And if you don't get respect and advice and essentially a referral to a gynecologist, then you need to actually change your GP. If they're not educated, you can bring, there's information leaflets out there you can get from the Endo Ireland website. You can bring it to your GP and say, I've got this and this. Look, I'm really suffering here. The public waiting lists are extremely long. I'm in there, the public system, because it was a pre-existing condition for my insurance. I do find once you're in the system, it's actually fine, and I got lucky. I did know the name of the good doctors because I do so much research on it. The CUM is now, I had a horrible experience in there in 2017. I am now under a different doctor in there, and they are fabulous. And they are an OBGYN, but their colleague is an amazing endometriosis surgeon, or has just very recently done his fellow in Australia. So they are so open to talking to each other. They're working as a team. They want to get nutritionists involved. They want to get pelvic PT involved. They're looking at pain management as well. And for the first time after a long time, my doctor got his colleague to ring me, which I just found was such a change in the attitudes. And they said to me, because I've so much other things going on, they don't want to do another exploratory lap. They would rather do conservative management. So there was a checklist for them, like, how's your GP? Will they give you emergency pain medication if you need to? Is there a pain management specialist, which I do have? And I had to fight for a referral for that one. And then referred me to pelvic PT because I did feel that would help again. And I'm managing so many different conditions. I've run out of money in terms of what I can put to the other therapies, like they're all going on consultants at the moment. So I've been referred to public PT. I think my waiting list is about 3 to 6 months on that, which feels like a very long time, but as opposed to the other 4-year waiting lists I've experienced, that actually felt like a
flash in the pan.
Flash in the pan. I rang last month for an emergency appointment, and I was given the 21st of October, which
emergency is the key word here.
Emergency is the key word, but yeah, so that's kind of the medical route. There is a Facebook group called Nancy's Nook, and they have a list of endometriosis surgeons worldwide that you can look at. They also have quite a lot of information in their pinned posts. I would stay out of, again, I said, like, stay out of the comment section. That's a huge group worldwide, so you don't know what you're running into there. Just stick to the education side of it. Get the list if you do want to travel abroad, if that is within your remit, or maybe starting with somewhere like the Coombe, where then Tala Hospital has an endometriosis centre as well, and they have a nurse there, which is, she's phenomenal in terms of the information that she has on medication and the medical side of things, like her hormonal knowledge in terms of maybe try this pill or that pill or whatever. It could be very helpful if surgery is not there for you. We've spoken about the differences between the surgery. You need someone qualified in excision who's doing that all the time. That's the thing, you need the experience, and that's very hard to get. So if that's not your avenue, maybe contacting somebody like those 2 endometriosis centres here. They might be able to give you the support you need, and getting your GP on side as well to help you with the day-to-day stuff. I know people with very severe disease can, like, occupational therapy, and that can help in that they're finding it difficult to get around their own homes or manage home life. Then an OT can be amazing for that and teach you little ways around. Like, I have a problem with my joints, so I learned how to not lift heavy steel pots, and there's lots of little kind of hacks in that. You can get like baskets for transferring to the sink. So if you're having a really high pain day, there is other supports there, particularly if you're on your own and you don't have somebody else who can pick up the slack for you when times are bad. And then don't be afraid to explore like complementary therapies. Don't be afraid to have a good long look at your lifestyle and see if there's anything in there that might be exacerbating your pain. And try and advise your friends and family not to give unsolicited advice, because that will cause more stress than anything. So if you are, say you are a partner or a very loving family member who really wants to help, we know that your heart is in the right place, but you just have to remember that we're hearing information from lots of unqualified people. So ask your partner or person who is suffering, do you want support or do you want solutions here? They could just want to rant, they're not looking for you to fix things, they just want to offload. Or if they want solutions, then you go and get Google yourself and do the research. Don't be expecting a person with chronic illness who can barely get out of bed to do all of the education for you. Go research yourself.
Yeah.
That could be really helpful.
That's a great bit of it. Loads of massive advice there. And I said to you earlier, I'm going to put all of these links. You've sent me so many different resources. I'm going to put everything up on the page on the Prymal website where this episode will live as well. And I'll constantly update that if you have more information, you want to send it over to me. Yeah, incredible, actionable takeaway tips there for people. Absolutely amazing episode. I had this conversation with you last week. I had another conversation with you over the weekend. And even today, I'm learning so much more. So it is really, really refreshing to hear somebody speak so openly and honestly about the realities of living with this, the actual way it's managed, I suppose, in the healthcare system, and give advice for people that is, again, I say, actionable and you can actually do something about. So it has really been enjoyable for me to learn about this, and has really opened my eyes. And I know there's people out there who are going to benefit massively. So I just want to say, from me, thank you very much, and on behalf of the listeners here, thank you very much for your time. Thanks for the energy you've put into preparing for this as well, because I know you put a lot of effort into preparing for this, and I'm sure we'll catch up again in the future. Maybe not on this specific topic, but you're obviously very well rounded and educated in the world of health and wellness, and I know there's loads of things we'll even touch on today. But I just want to thank you very much for joining me here today.
Oh, thank you, and thanks for being so understanding. There's not many people who are giving a platform like this to speak on, so I really do appreciate it. Thank you.
Absolute pleasure. Guys, thank you so much for listening to this beautiful episode of the Prymal podcast with the wonderful Sarah Moloney. I hope you learned a lot today. I most definitely did. Every time I speak to Sarah, I learn more about this condition. As I mentioned at the end of the podcast there, if you would like any more information on this episode or anything we spoke about, or if this affected you in any way, head over to www.prymal.ie/Sarah Moloney. All of the information, all of the links, all of the resources that she has sent me or mentioned in this episode will live on that page. And as Sarah sends me more information into the future, I will continuously update that page. Once again, thank you so much for listening. I hope you learned something in this episode, and I'll see you next time.